Good morning, good morning. Good morning, Austin. Good morning, CVI. That's fantastic. Well, listen, welcome to another amazing, exciting, and full of education, cardiovascular innovations here in Austin, Texas. This is our 8th year, Subhash, 8th year of cardiovascular innovations. We are very excited. The format of this meeting is very different in regards to the style of education. Very informal, and we call it family-oriented, very close to each other and asking questions and engaging the audience. So I hope there are a lot of questions that are going to come up during the presentations, and we're going to engage the audience as we go on. This morning's session is going to get us started with Dr. Tarek Hammad. He's going to be discussing retrograde pedal and digital access with a case presentation.
You're supposed to walk down, look at the timer.
Great. There's a bright light. Awesome. Okay, well, good morning, everybody. Thank you, Dr. Shishehbor, Dr. Banerjee, for the invitation. I'm going to start my slides. No? Okay, no disclosures. Okay, so history presentation. This was a 76-year-old man recently moved to Cleveland from out of state, and he established care with podiatrists for non-healing right foot wound and severe persistent claudication. So he was referred to me. This is June of this year. His pertinent history: he had recent revascularization. Is the voice okay? I feel like a lot of echo sound. Or no, it's okay. Good. Okay, great. Okay, so in April of this year, he was, he got revascularization of his right lower extremity at out-of-state hospital. And at that time, he was told that there was a thrombus in his right leg, and he was placed in Lovenox. Other history, I'm not sure the slides here are not, well seen, but here, hypertension, hyperlipidemia, emphysema, typical PAD patient, RCA-CTO, cardiomyopathy of 30%. Okay, so this is a clinic visit, I think probably mid-June now, like June 17th of this year. You can see he has tiny skin changes in his right great toe, some non-healing tiny superficial wound, in the other side, and you can look at his ABI and TBI. You can see the waveform at the PT and DP. They're very flat and damped, severely damped flat, and his is consistent with severe PAD CLI. So his PT and DPs are 0.32, 0.28, so less than 0.4, and his TBI is 0, flat line. The high thigh waveform multiphasic looks good. So we actually were able to obtain the outside hospital images from out of state, and this is the angiograms they obtained. I'm sorry, the image quality is not the best for these images or out of side images, but you can see in the first panel, I didn't put all the clips for the sake of time. His iliac system and CFA were free of disease. His SFA looks like a CTO, as you see in the first panel. Distal SFA is a CTO. And from the second panel, it looks like it may reconstitute. That's hard to say, probably around the pop level. It's not clear if that's probably collateral or not, but look like distal pop comes back. The runoff on the third panel is not well seen, but you can tell from the last panel that he has a distal PT flying with to the foot with a plantar and distal AT to the PD. Okay, so it looks like they tried to cross that distal SFA CTO. In the first panel, you can see the wire. I didn't put all the images, but looks like they were able to cross, and they confirmed true lumen position by distal injection. As seen in the second panel, all the tibials are filling. And then the third panel, they proceed with balloon angioplasty. And on the fourth last panel, this is what they got afterwards. Any questions so far?
Doctor, I was going to ask Dr. Das, Tony, what are you thinking here? If you had, looks like let's call it a CLI case, Rutherford 5, right? And Tarek has crossed this lesion and ballooned it.
So I'm sorry, this is the angiogram from April outside. This
is still outside?
Yeah, this is when he presented with claudication. The wound was afterwards. At that time, he had only claudication.
So this procedure was done in another place by someone else for claudication?
Absolutely. Thank you.
This is a typical look of post-intervention with balloon angioplasty alone with a fair amount of recoil. I can't really tell if this is really thrombus. I mean, they obviously thought that this was, but, sluggish flow from incomplete revascularization will give you this look, so that's not too surprising. I'd like to see what the tibials look like to sort of define. If the outflow looks good, then I can start working on this with something more definitive. If the outflow looks bad, it sort of changes my approach to what I would do more proximally. I assume this was a non-drug-eluting balloon?
Yeah.
Probably a standard balloon? Yeah, so I think you need to show us some more, but nice job so far getting through, but I think that the proximal piece is still yet to be determined what to do next.
Okay, good. So
Can I just ask one more question?
Thank you.
Peter, what's like we are not sure right now. I mean, I'm thinking, is this clot? Are they subintimal? This was the proximal cap. Should we do some kind of imaging at this point to define this better, or is it better just, go with the flow and see what should we do here?
Yeah, you're reading my mind, Mehdi. Get out of my head. I was thinking that this would really be a nice time to pull out the IVUS and see exactly what's going on for a variety of reasons. It's really difficult to say, is this dissection? Is this old clot? What are the size of the vessels? Given the fact that this is an occlusion, I think there's a fairly high likelihood you're going to end up needing a stent here. For all those reasons, I think I would probably want to just image this and get a better feel for what I'm actually dealing with, because that's going to have a direct impact in terms of what my subsequent treatment decisions are going to be.
Great points. I think very great points. Actually, credit to the outside operator. He did use IVUS, but I didn't show the image, but he did use IVUS. And, he decided, to proceed with thrombectomy. So they put a filter in Bushfield. He did a couple runs of, thrombectomy. And this is the final angiogram. It didn't show the tibials. Tibials looks the same as they looked at baseline. And this is the final angiogram. At this point, he decided to stop. So I guess he did multiple runs. He ballooned again. And he still got the same results. So decided to stop and put patient Lovenox.
I didn't miss it. What was the IVUS? What did it show?
So he used IVUS. He called it thrombus. So I don't know, but he interpreted it as a thrombus. That was interpretation based on his IVUS, and angiogram findings. So he did multiple runs of thrombectomy, balloon angioplasty, and then at this point he decided to stop, place patient Lovenox. And I think the plan was for relook, but patient moved to Cleveland, and at that time he developed wound. So now I'm seeing him after he got referred by his podiatrist. But we got the outside images, and those were the outside angiogram. Okay, so I guess we decided to bring him. I think this was early July or last day of June. We brought him the cath lab at UH, and this is my baseline angiogram. So I went up and over, same. I confirmed the ilio and CFA are free of disease, and this is my baseline angiogram. It looks like the SFA is a CTO, occluded of course, and this is his the second panel. You can see the distal pop. I don't know if it comes back, but definitely you can see, the distal pop here. Late, you can see the AT, TPT, PT, peroneal all come back. And he has a nice runoff to the foot via the plantar and DP. So what would you do at this time? Like based on the angiogram you have now and based on the history and everything from outside?
Just for curiosity, what was the leg like?
The other leg was fine. I didn't show the PVR, but the PVR was normal for the other leg.
Cirrhosis.
I can tell you my thought process, but
Your basic choices are you want to cross up and over, antegrade, or come retrograde. I think that's the basic
You're right.
choice. If you had the previous IVUS, it would help you decide if you're subintimal. But I think it is safe enough to go retrograde here, I would say.
I agree.
You have clear targets, you have a very good PT, and I think you will have much better chance crossing it successfully.
I agree.
That's my
Thank
view.
Thank you. So honestly, looking at the angiogram, myself, I felt very confident, even though they used IVUS, that this was more subintimal dissection. I mean, the way it looked, I mean, I felt like the look, it was not unfamiliar. We always get this result post-angioplasty. So in my mind, there was no thrombus, even though they did IVUS, but who knows? So in my mind, this was a subintimal dissection. Honestly, I want to go up front with retrograde, and, but I said, let me just get a feel with a stiff and glide. Okay. And actually, it flew through till the popliteal, so I knew that was moving too free the tip, that I knew this was a huge subintimal dissection. And that as soon as I reached the popliteal, the wire would stop. So I said, okay, I've just got a sense, and I'm going to go retrograde. So at this point, We obtained access. Let me show you.
From just one quick comment
Yeah.
from a retrograde perspective. The location of the wound is in the toe, is that correct?
He has a tiny skin changes in the right great toe, and then he has some a tiny superficial wound in the lateral side of the right foot.
Okay. From the panel, if you have, it seems like you have actually two very good retrograde targets. Does the location of the wound factor into which one you think would be a better option for retrograde access?
Undoubtedly for me, PT. Undoubtedly.
Because of the location of the wound.
The location of the wound and also the access caliber, I would say the location of the wound is primary.
I passed, good.
I would actually challenge that. So we do have to take into consideration that the angulation of the AT might be unfavorable for us to cross retrograde sometimes if it's very angulated. However, given that both of them are about 2 to 2 millimeters in size or so around the ankle, I would say that either of them would be decent target distally. What I would be worried about is, for example, if you had to put a sheath into retrograde, into the PT, I would probably favor the other one, the dorsalis pedis or distal AT, just so that I don't mess up the inline flow into the flow of the target zone.
Thank you. Great points. You want to say something, Dr. Shishehbor? Go ahead, please.
There are different schools of thought, right? There's one school of thought that, go to the most diseased pedal. So if you cause some damage, it's already diseased, which is what I think June is saying. The other school is that, well, don't waste a lot of time. Go for a nice target, because if you are careful, if you're using ultrasound for uroscopy, and you're careful, it's unlikely that you're going to damage the pedal. You can damage anything if you don't know what you're doing. But if you have experience, if you know what you're doing, you shouldn't be damaging the pedal arteries. Just like you could damage a groin if you don't know what you're doing.
Absolutely
So
correct.
as long as you're careful, you can do it. So I think there are two schools of thoughts in this.
I agree. One thing to add for me, I think I decide based on the size of the wound. Like if this was a huge gangrene, I think I need a lot of blood flow. I would try to avoid that angiosome. But for that tiny wound, I think any kind of blood flow would heal it, to be honest. This is very tiny, not big deal. So I thought, either PT or AT would be a good target. Can we move the slides forward or not moving forward, please?
I think the other thing to consider too for us surgery colleagues is the distal target, which I know, when you access correctly, you don't tend to damage it. But for us, we're looking at it and we're like, that's a bailout option for us.
Thank you, Jane. Great point. Okay, so we came, I chose the PT retrograde. We crossed with a command wire with a submicrocatheter CXI. We externalize a wire, as you see in the second panel, through an antegrade navicross. We balloon DCBs, and then on the panel before the last, this is what we saw. So to me, looks like awful. He had already dissection. This looked like an awful, not uncommon, unexpected dissection post angioplasty. So I decided to treat this, dissection and at the distal SFA level and leave the pop alone, hoping that it would heal with time. And you can see the dissection stent all the way to the distal poplite. So we put a stent, a little bit underexpanded, post-dilated. The third panel is the post-stent result. The image is flipped. And you can see there is residual, maybe 40, 50% dissection in the poplite. I thought I'd leave it alone, good flow, non-flow limiting. 3 vessel runoff, and on the side, you can see the foot has a lot of blood flow.
Tarek, it is interesting that from the initial angio
Yeah.
to your angio, the dissection or that area has actually extended distally. Did you notice that?
Actually, if you look, I know the outside images were a little bit, not the great quality, but somehow in this app, they don't look as good. But in the computers, I was able to review that dissection looks extended already to the poplite. And when I put my stiff anglide wire in just to go through, it was very free. I thought I'm through lumen. And then till the end, some resistance, I knew this is where probably the dissection from the prior, angiogram kind of stuff.
I'm very competitive. I have to get back to June. Because you can imagine the reason I made that point, and if you agree or disagree, when the dissection extends into the popliteal, especially into the third segment, coming from an AT and trying to re-enter and do a rendezvous is very, very challenging. Of course, it's possible.
Yeah, it all depends on the angulation of the ATs. Exactly.
What is your choice of, since we're talking about pedal access, We talked about the decision, but how about from the standpoint of the wire? Do you ever use the wire that comes in a kit? Are you using a support catheter? Do you put a sheet? Can you quickly go over the algorithm, what you do?
Thank you so much, Dr. Shishehbor. I think this is the only time I probably deviate from what you taught me. I don't use a command up front. Just because I'm a cardiologist, so we do a lot of radial with the stainless steel wire, so I have a very great experience with the feel. So I always like to use this wire to access the vessel because I know exactly how it feels and how it's not supposed to feel. So I use that wire, and as soon as I get access, I don't use the micro sheath. I use it as a microdilator and exchange that to command. But I use a microneedle, the micro wire, and then exchange to command using the dilator of the micro sheath.
That's great. How about the panel here? Jane, what do you like to use? Do you like to use the stainless steel wire that comes in the kit, or do you use like a command a workhorse wire?
Well, I was taught by you, so I use the command.
Peter, what do you do? We have a problem here.
I'm a command guy.
Subhash.
For the access, I use what comes in the kit, the short wire. But
And then you upgrade to a...
if I have to, yeah, that's what I do.
Tony.
Sometimes I like using the Coke mandrel wire here because it gives me a little directionality. The one that comes in the kit, sometimes if you're against a wall, it'll immediately start to ruin the tip, and you think that you're in and you can mess up your access. The other thing is that I rarely put sheaths in these. I'll basically just put a support catheter, do the whole case from the support catheter in the sense of, everything from below and then snare from above, and then do my stenting if I need to from above. It just makes the final result look a lot better, and also, you want to make sure that the outflow is preserved.
So
go ahead.
Yeah, so I think I use, I forgot to say, I use a command if that target is diseased. So if that PT I need to access has a CTO very distal, or that access PT is very diseased, I still use the command. But if it looked like this, I would just use the regular stainless steel wires that come with the kit. So this is his post, this is mid-July follow-up, just barely like 2 weeks ago. And you can see his PVR had improved from 0.3 to 0.28 to 1.1 to 1.3 normalized, and his TBI is now 0.62, nice waveform. So key teaching points for myself: always request, review, and carefully study outside angiograms. So make every single effort. Doesn't matter what the reports say, what they thought. Always make all efforts to bring this image and review them carefully, and plan procedure, and be ready to change the plan. Depending on what you find. So be dynamic. In many cases, like Dr. Shishehbor always say, you cannot be a CLI operator if you don't know how to get a retrograde access. So it's very crucial, and honestly, in some cases, I think, especially the first case, if I probably got this case up front myself in April, I probably have gone a retrograde first, because there were plenty of collaterals. It would be very hard to go through the true channel and get just straight without getting sided by the collaterals. Thank you so much.
Thank you, Tarek. Well, let me invite Dr. Yulanka Castro. This is a skill she's going to talk about that I'm still learning, and the next generation of operators are going to teach us how to do it perfectly. So Dr. Castro, it's over to you to talk about R2P, and starting with describing the abbreviation. Here is your microphone. And Tarek, was it hard to read the podium? Yulanka, you can do it from here.
Maybe I'll just do it from here. I'll do it from here. So I can. Yeah, thank you, if that's okay. Good morning, everyone. So I'll be talking about radial to peripheral, and just have a few rapid fire cases to discuss, and I would need the help from the panel and get their opinion as well. So the first case is of a 60-year-old man, smoker, that came to us with rest pain. And actually this case was interesting. It was actually one of our colleagues from an outside hospital actually tried to do this case, as you guys can see, hopefully when the image stops, is, very, very severe right common iliac stenosis with an area of CTO segment as well. But it's at the very ostrum of the common iliac, the area of severe stenosis. And the outside operator actually tried to go up and over to try to fix this stenosis in this patient. However, due to the severe stenosis at the ostrum of the iliac, they were not able to go up and over. In addition to that, if you guys can see, the proximal SFA is occluded. The proximal surface occluded, what you guys can see at the bottom is just the profunda coming out. And truly, there's not a really good, since it's a really high bifurcation, there's not really a good area for access, actually, for ipsilateral access. So this was a trouble that my outside colleague was running into. Reason why they asked me, hey, I heard you do radial interventions. What do you think about targeting this from a radial approach? And which I think is, pretty important to understand this skill, because it's a key access for treating osteal-common iliac lesions, and when you, like in this case, there's no proper landing zone for ipsilateral CFA access. Thoughts from the panel on how to target this?
So, Yulanka, you think Yulanka?
Yeah.
So this is a diagnostic angiogram that was from the referral team, is that right?
That's me already. I'm
That's
already
you
going radial.
Okay.
Yeah.
And you interpreted it. Is there any other image? Is that an occlusion or a subtotal occlusion or a total occlusion? What do you think?
So the ostium is a severe stenosis.
I see.
Which they kind of degraded a little bit, but it's a severe stenosis at the ostium, and then there's an area, the proximal common iliac, that's completely occluded. That's 100% occluded. And then down in past the hypogastric, there's an area that's completely occluded as well. Yeah. Any thoughts on how to approach it?
Well,
yeah, I would have liked to have seen maybe an angulated view of the CFA bifurcation, because I'm not 100% convinced that a retrograde femoral approach is out of the question here. Correct. The reason why I would love to do that, for a couple of reasons. Number one, you can put in a larger sheath than you can from the radial. Number two, if it's a calcified CTO, you're going to want to think about maybe vessel prep with IVL, in which case, having the ability to have a 7 French sheath would be nice. Number three, if in fact it's calcified CTO, there is a potential risk of iliac rupture, which would obviously be catastrophic and immediately life-threatening. So having a 7 French access where you can quickly throw in a VBX to bail yourself out in the case of a rupture, for all those reasons, ideally would love to be able to come from a retrograde right access. If the SFA is occluded, I don't care. If it's a reasonable, if the groin over the vessel over the femoral head is patent and I can stick a 7 French sheath in there, I'm probably going to want to do that. You're in all likelihood, given the fact that this is an osteal right common iliac, you're probably going to end up having to do kissing stents for the bifurcation. So you're going to be getting retrograde femoral access on the left anyway. So those are I like R2P, but I think we have to recognize that there are limitations, and I always get a little bit nervous about doing iliac calcified CTOs from the wrist and not having an immediate bailout option, an immediate ability to put in an aortic occlusion balloon and or covered stent.
I think it'll be good to ask the surgeons how they would approach this. Dr. Eidt and Dr. Chung?
I agree with the point about the kissing iliac stents if we wanted to keep it truly endovascular. I think one of the other options that I regularly use if it looks like this is contralateral femoral access with use of a steerable sheath, and that way you can go up and over the bifurcation to treat osteal lesions.
What happened?
Great thoughts. Yeah, and that's one of the reasons that I think that that's our operator. Their concerns were when they were trying to, with ultrasound, assess if they could get ipsilateral access. They thought the access was too high, and when they did their initial angiogram, which I didn't put in, they think it was not a good, not suitable for a good, safe common femoral artery access. So in this case, my approach.
Not moving?
Okay, now it's moving. Okay, so I decided to get a 6 French radial with an RTP sheath, 119 centimeters, that goes all the way to the ostium of the common iliac. And initially, my thought was, let's see how if I'm able to cross this wrist from approach from above, and then image my iliac and understand what I need to do. However, when I was going from above, I kept just staying into an subintimal space. So that's when I decided to actually save ipsilateral access in the common femoral. And since I did not think that I had actual, based on my ultrasound, good landing zone to actually place a sheath, I actually just got sheathless access. So I was able to obtain ipsilateral access in the common femoral and just go with a catheter and an 035 wire in order to be able to cross. And I actually was able to cross really well with a Navic cross and an 035 wire. And as you guys can see, that's another image where I truly feel that I'm true lumen with my ipsilateral access, and then I'm able to cross and actually feels pretty smooth overall, much better than my access from above. And then after that, once I'm able to advance my wire all the way to the aorta, and I'm able to snare my wire and then sterilize, and then I image with IVUS, I confirm that I'm true lumen all the way, identify how calcified, how severe, my landing zones, my sizes, then I'm able to actually safely stent. So in this case, I decided to place a self-expanding stent in the external iliac all the way to the distal common iliac, and then I actually placed a BVX in the common iliac that, now with the better profile, smaller profile, I was actually able to place a 7 BVX and actually made it bigger with post-dilation. Actually got really good result without needing to actually stent the other side. And his stress pain resolved, and then we, planning to, if needed, address the femoral on another occasion.
One of the things that I think has been a real significant advance just from a practical standpoint is that the VBXs, most of them will now go through a 6 French. And so that's huge. So in a situation like this, now that you have that device available, if God forbid you had staining or perforation, you still probably could have bailed yourself out even from a radial approach with a 6 French sheath now that those lower profile VBXs are available.
I think another good point for these cases is that despite your angiographic confirmation, intravascular ultrasound for iliac crossings is imperative, because you can, if for any reason you're not using a covered stent, if you think it can be much more important, because you can actually extravasate even after stent post-dilation. And I think that's a good approach. So tell us, if the R2P access here was more helpful to you get angiographic guidance, or it was more useful for everyone to actually get back into the true lumen? So the alternative would be you didn't have R2P, you had a catheter placed on the contralateral groin, and you were able to get angiographic filling of the distal iliac, and you were trying to cross retrograde from the right side. How that would have been much more difficult, easy, or this was something you planned?
Yeah, I think the difficulty in that scenario is that if you want to try to deliver equipment, if you're not really engaged up and over, it will be pretty difficult. So that would be one of the challenges. Although if you can, if you're able to cross from the other side and you snare, you may be able to move your sheath all the way from up and over. So that's another approach in order to do that as well.
I think the other advantage of this R2P in this situation is when the lesion is in the common iliac, but you have a short landing zone in the ostium, coming from the top gives you more security, not to have to put kissing stent. I think in the old ways we used to do it, you coming from the bottom, it's hard to be 100% sure. So I think we had a lower threshold to put, two stents. I mean, in my practice early on, I used to always get by. For a lesion like this, I probably would have gotten access in both groins, because I would have thought that, probably have to, for that first lesion in the common iliac, I probably have to protect the other side. I maybe have to do a kissing stent and all that. I think in this situation, you get away with doing an outpatient procedure that you send the patient home in an hour. You get to get nice diagnostic angiograms from the top, and you'll be able to deliver VBX. And if you get into complications, you have opportunity to use covered stents. So I think that it makes a little bit of sense in that kind of a mindset.
Perfect, thank you. Next case. Okay, so this is another case of a 69-year-old man with diabetes. PAD had a prior aortic bypass, and he's coming in with CLTI, with a wound and gangrene and osteomyelitis in 4th and 5th toes. So there's another scenario where I think radial to peripheral access is actually pretty helpful. When you have an aortic bypass, it's prohibitive to actually go open over, and for some reason you don't want to do like an antegrade access, for example. This is a patient with an aortic bypass, and kind of just quickly going through this case. So we can see his aortic bypass is, completely patent, no issue with the aortic bypass overall, but he has a mid-SFA lesion as well as proximal tibial lesions as well. And using radial to peripheral access, we were able to actually, very well cross the SFA lesion, cross into the anterior tibial artery, balloon the anterior tibial artery as well as the SFA. And then we were able, now with the newer drug-coated balloons that are also have enough length to be able to deliver and to treat the mid to distal SFA, we're able to treat that as well as anterior tibial artery as well. And he was able to heal his wound. Then I have another case.
So in that case, Yulanka, did you have a pedal access, or were you able to reach everything from the wrist?
I was actually ready to do pedal, but I was able to actually reach everything from the wrist.
So the DCB and everything reached all the way from the...
Yeah, because now we have 200 centimeter shaft length drug-coated balloons that are able to be delivered and that deliver really well and actually reach to the mid to distal SFA. In addition to that, also regular balloons that have enough length to reach the proximal tibials as well.
Just to play devil's advocate, what would have your bailout approach been if you had a nasty dissection and you needed to put in a stent?
That way I have retrograde access. Retrograde access. I'm ready to get retrograde access in order to, if I need to deliver a stent, or even antegrade common femoral access if needed. But I was trying to keep it simple and for this patient in this case scenario. But yeah, always ready. I think it's important when we're doing radial access to always be ready to get an additional access, right? If you need to get common femoral, if you need to get pedal or another distal access, because you need to be ready for complications, or you need to be able, if you can't cross the occlusion, you need to be able to do it from another approach.
I think you make a really good point here that if you're going to do R2P, which is about a 5% adoption rate so far, that at our center, actually, we have an operator, Sammy Safo, that loves to do R2P, but the beauty of that engagement is that the companies that are making these systems have now continued to provide balloons and other catheters that allow you to complete the procedure. I think the reason why a lot of folks will not adopt R2P more was previously there were cases that you couldn't finish, or cases like Peter mentioned where you might have a complication or an issue, so you couldn't plan on fixing everything from the radial access. But I think that now with the devices that we have, and it's probably worthwhile for folks looking at a case like this to go into their supply closet and figure out, do I have the lengths of wires that I need, the lengths of balloons that I need, the shaft lengths, are these over the wire and the wire's too short? Are these rail balloons? And know that the compatibility exists in your supply closet before you start one of these cases. And now, because we are a site that does a lot of R2P, we have those things. But I can tell you, if I do a case at another center, I can't complete the case sometimes because of the lack of equipment that exists.
Excellent, great points. And just a final case. This is another reason why I think the title is wrong. It's actually hostile. It's actually terrible groin in this scenario. This lady, 70-year-old, smoking, diabetes, presented with right fifth toe gangrene. As you guys can see in her ABIs, severe right disease that definitely concerning for inflow disease. And in addition to that, these are her groins. And I know Dr. Chung is like, nope, don't cut them on those. So the reason why, she had a CTA that, we were able to identify that she had also significant aortoiliac disease specific on the right side that needed to be treated. And in her case, given her hostile groins, we decided to do radial access as well. In her case, we actually did bilateral. And we were able to access both sides and just, to get her the treatment that she needed in order to heal the actual wound. It was just enough to actually do, and in this case, we did kissing common iliac stents in her case. And she actually healed the wound, and I actually didn't put that in the pictures, but her ABI is normalized. And this is just kind of a brief talk. There's right now, as Dr. Das was mentioning, the adoption of radial to peripheral is actually pretty low, less than 5% overall. But there's only one actually large prospective registry of 120 patients looking at, from a multi-center standpoint, looking at multiple operators and understanding different practices for radial to peripheral interventions and enrolling patients with complex lesions. So these are patients that had multi-level disease, that needed orbital atherectomy, that needed different accesses in order to complete, and the success rate was actually 93%. So it's doable, you just gotta plan, you gotta have the proper equipment, the proper devices, and you gotta identify the patients that it's actually you would work on. But it is definitely doable if you plan for it. And actually, we have now an AHA statement on radial to peripheral interventions, and this statement, I encourage for anyone that's interested in doing radial to peripheral interventions to read through it, because it talks about who are the proper patients, who are the proper lesions that should be targeted, and we're talking about patients where, they're type A, type B lesions. We can also do also more complex if possible, if you have alternate accesses as well, and looking at those that have contraindications for femoral access, for example, or there would be high risk of complications as well. We talked a little bit about the available tools, and I just want to highlight now we have drug-coated balloons that are 200 centimeter shaft that are on over the wire and also monorail as well. And for atherectomy, we have available as well now orbital atherectomy and also laser. Shockwave now it comes in 150 centimeter shaft for the Eidt catheter. Hopefully we'll have bigger catheters as well coming soon. We only have few self-expanding stents that would be potentially approachable, and now cover stents, some BVX are 6-French compatible as well. My wish list, I want more options in wires, microcatheters with increased possibility. Thrombectomy device would be great to be able to do it from radial. That actually reaches all the way to the SFA, would be fantastic. Distal embolic protection devices along with it. We need also self-expanding cover stents. And also, as I mentioned, larger IVL and re-entry devices. In summary, radial access for peripheral interventions continues to be a key tool for the management of complex PAD patients that have, radial here is a tool that you can use. It's not that you want to make your life more complicated by getting radial access. If it's something that you needed to do it, we gotta have the devices and the equipment available for it. And we need to push the industry to continue to develop and improve on the current devices to make them suitable for this approach. Thank you.
Thank you, Yulanka. Thank you. I just want to add, Yulanka, from our group, from Baylor Scott and White at TCT, Sam Saifo is the PI. He's going to present a 600-patient propensity-matched angiographic and clinical profile of 300 radial and 300 femoral. Hopefully, it'll get accepted at TCT, so stay tuned. But fantastic. I learned so much from you today. Thank you, Yulanka. Thank you so much. Let's invite... Yeah, question. Hold on. Okay, go for it. Yeah.
Thank you. Great presentation. So I delved into R2P a little bit. My two major problems were, one, the wires that you mentioned, like glide wire is a slippery wire. You lose position, you have to cross again. Wiper wire is not a great wire. The second one is IVUS. IVUS will not reach the SFA. And so what are your thoughts on that?
That's a great thought, and that's one of the reasons when you got a plan, you understand what your disease is overall, where either having some more non-invasive imaging beforehand might be helpful, either ultrasound or CTAs beforehand if you want to understand the lesion, or get retrograde access if you really need to do other imaging. But I agree with you. We need, in addition to that, we'll add that to the wish list as well. We need longer shaft IVUS.
But this is, I think, Tony, I think you said it, this is how the emerging technologies work, right? You come up with a technology that as long as there is some uptake, then the companies are looking, they're like, well, you know what, this is an opportunity. And, for me to have longer IVUS is an opportunity for me to have longer IVL because there is an opportunity in this for growth, for a business opportunity. So I think having these tools, and I'll be honest with you, after doing this for a few years now, is a huge difference from a patient's perspective and the team's perspective, going radial versus going antegrade. From a time consumption, the pain and the suffering of the patient and the team and the fellows and that have to hold pressure. And then every time I've tried to use a closure device for antegrade, there was a complication. So I don't even use closure device in my own practice. I know others use it. So there are opportunities here for growth, and hopefully companies will pick up and bring new technologies to us to make these procedures much more feasible.
I don't know whether Zach is here or not, but we use the R2P sheath for difficult contralateral popliteal delivery of sheath. They're actually fantastic. If you have iliac stents or SFS stents and you want to get this thing, the 114 centimeter sheath is a perfect. So technology advances with use, and that's a great point. Yulanka, fabulous. Thank you so much. Well, let me invite the two operators for this recorded live case by Dr. Jun Lee and Dr. Mehdi Shishehbor. Jun, how are you going to do this? You're going to play this and stand here on the circle? We have designed this special circle no one wants to stand on.
But then it blocks the view of the audience to you guys.
Of course.
I want to do that. We can go ahead and play the video. Thank you.
Before you begin, is that top floor Mehdi's office? No?
Well, good morning. Thank you again to Cardiovascular Innovations for giving us the opportunity to present a taped live case. We are here from University Hospital's Harrington Heart and Vascular Institute in Cleveland. I'm Mehdi Shishehbor, and I'm excited to share with you guys a case with our team here. Let me just introduce the team quickly. We have Dr. Butkin, who is a vascular surgeon, fellow who's working with us. We have Dr. Atif Rana, endovascular interventional cardiology fellow, graduating in 1 month. We have Taylor, who is one of our podiatry students that's working with us. We have Leah, Nick, Dante, and Milan in the back supporting us with nursing and the tech support. And then to my left, I have here Dr. Noor Tashtish, who is also one of our endovascular interventional fellows, graduating in a month. And then, most importantly, we have Dr. Jun Lee here, my partner, and we are hoping to showcase a very nice case of multi-level disease with CLTI. With that, I'm going to hand it to Dr. Atif Rana, who is going to go over the case. Atif?
So this is chronic limb-threatening ischemia with a non-healing wound. So this is a 71-year-old female with history of coronary artery disease, hypertension, hyperlipidemia, CKD, diabetes, and has very complex peripheral arterial disease for which she has had many interventions. She has been treated at outside hospital and has multiple surgeries as well as endovascular procedures done on her a couple of years ago. She was advised below the knee amputation bilaterally because she had desert foot, and that's why she presented to us for second opinion. So I'll just go through the initial, most recent procedures. In 2024, she had a left CFA endarterectomy with patch angioplasty, and also had a TMA at the outside facility. And in the same year, she was sent to us because she was found to have no flow below the knee vessels. So we had a procedure initially in 2024, and after that, most recently, we have done a procedure on her in January 2025, when we opened her SFA with DCB right side, and also the rotational atherectomy of the PT, and did a PTA of the anterior tibial artery. Now she presents again 4 months after with recurrent wound and in the right TMA that had been done in our facility. She is on low-dose rivaroxaban, clopidogrel, statin, cilostazol, and blood pressure medications. So I'll just go through the last ABI prior to the procedure that we performed in January. So you can see that her ABI was 0.55, and at that time she had a non-healing wound. Following our procedure, her ABI improved to 1.05. And now she presents again 4 months after, and her ABI has gone down to 0.42, and she's having a non-healing small wound in the same area. So we are going to start with that, and then we'll move on. Thank you.
Yeah, unfortunately, it's a very difficult to diffuse disease with AT, bunch of little collaterals here and there, hard to make. Let's go maybe lower to the foot. What do you think?
Yeah.
So there's a level of AT, but not great. And then PT, we don't really see much. It's a tough situation.
I guess the question is for
Let's pause the video.
So ultimately, just in summary, this patient has had multiple interventions to the right lower extremity, coming back in with restenosis, essentially, of the entire anterior tibial artery, as well as the dorsalis pedis. And previously, we had attempted atherectomy. Unfortunately, despite that, she still reoccluded. So I guess now the question is, what will we change at this point?
Let me just, maybe I can put some context into it, too, if you don't mind, June. So this was actually a patient that was referred to us by a prominent center, and the patient had bilateral lower extremity foot ulcerations. She was offered bilateral Benoni amputation. Her husband is a former dean of a very prominent university, one of the universities in the state of Ohio. And they were not excited to consider a bilateral Benoni amputation for her. So she was referred to us really for DVA consideration. So she was originally referred for DVA consideration. And when we did the angiogram, we thought that there was an opportunity to try to revascularize this. So we were able to revascularize both legs. The left leg did well and healed. The right leg kept recurring. And we will intervene, we get a reasonable result. You saw the ABI would improve, the wound would start getting improvement, get a little bit better, and then it would close, and then the wound stall. We'll go back, intervene, open it up, the wound get better for a couple of months, and then we'll get back to this situation. So this is where kind of the situation is. One leg has healed, the other one, the one that we are talking about right now, has had 2-3 interventions, all below-knee kind of angioplasties that are successful, get some improvement, but reocclude again.
Can I ask one quick question? One quick question, June. So when you did the rotational atherectomy and the angioplasty of the AT, was that where was the location of that? So I guess I'm just thinking, if you're going to do anything differently, could you, for example, use coronary drug-eluting stents if it's in the proximal half of the tibial AT?
Yeah, the rotational atherectomy was performed in the more proximal area of the AT. At that time, it was just pure balloon angioplasty that followed, obviously. No stents were placed at the time. Definitely in patients that undergo our kind of a first intervention, we don't always reach for a drug-eluting stent or a bowel-resorbable scaffold, especially if the angiographic results look reasonable. In our opinion, kind of if you have dissections and flow-limiting dissections especially, those are the patients that might benefit from a scaffold. But in this specific case, in her first procedure with the rotational atherectomy, it was just balloon angioplasty. Why don't we go ahead and play? If you can mute the audio so that we can talk over it.
Please mute the audio. I hate to hear myself. It doesn't sound good.
If you can fast forward a little bit, I know I don't have, oh, there it is, perfect. So you can see that the dorsalis pedis itself really is non-existent beyond the mid portion with no meaningful pedal arch. I will say that
we have an angiogram, June, of the leg.
I don't know if that part actually got cut out. If we can fast forward a little bit, I think we actually already crossed at this point, but it was occluded in the anterior tibial artery proximally, approximately about an inch into the AT, the initial angiogram.
Basically, there was nothing in the foot, as you saw. I'm sorry, the angiogram looks like it's been cut off with the editing. But bottom line is that there's nothing below the knee, and and every time we have gone in, we were able to open up the AT, get a reasonable result all the way to the mid-foot. She has a TMA, and then looks reasonable. She comes back with a reocclusion. So the question was that what are we going to do differently this time? Honestly, the purpose of this case was, it wasn't so much the crossing that was going to be challenging because we had done it 2-3 times. The question was that what are we going to do differently this time because the wound wasn't healing. Yes, Dr. Carmen? Yeah, so I think we are becoming more and more aggressive, with the compass kind of a mindset. So in these CLI patients, so when we have recurrence of reocclusion, we don't put everybody on, historically we always did that, right? We did aspirin and clopidogrel. We started changing a little bit in the high-risk patients, doing the monotherapy antiplatelet with the anticoagulation, 2.5, Xarelto. We then changed again that practice in a sense that now we are typically in this kind of patient with recurrent intervention, we do Plavix with the Xarelto kind of a combination until the wound heals. Once the wound heals, especially in these ice below the knee kind of patients, we then stop the Xarelto and just do monotherapy Plavix. What are your thoughts? Yeah, so the question is, obviously, she was on high-dose statin therapy, and we tried to keep the LDL in these patients less than 50. Dr. Carmen is asking about silastazol. As you know, it's a phosphodiesterase inhibitor. There is some data about restenosis, also vasodilation, anti-inflammatory, and so on and so forth. We don't historically put people in this context on silastazol. I know there is some data out there, but there's obviously reasonable data for claudicants. I don't know, are you doing that, Subhash?
No, I'm actually not doing that, but I would start if I see this patient. But I have a much more fundamental question I want to ask the surgeons. Dr. Eidt and Dr. Cho, when you have regular garden variety CLI patients, and even if you provide temporary flow, the wound actually heals, even if it recoils later. Why are TMA wounds, what is special about a post-surgical wound that I don't see very often that does not behave like that? Any thoughts? Because what is striking is, in my limited view of TMA wounds, is that there is no induration, there is not much inflammatory changes around that area except for the non-healing wound. And what I have seen is that even if my angioplasty didn't succeed, even if the flow was there for 3-4 months, you actually heal the wound. So this one doesn't. Surgeons, anything that is different about this wound?
I think there's a lot of other components to the wound care, including offloading and the different pressure points that exist when you do a TMA. You kind of alter the foot anatomy and possibly their gait and the pressure points. But to your point, I don't particularly know why that wound tends to persist.
Can you pause the video while we talk? Thank you.
Dr. Eidt, you have any thoughts on this?
One of the first thoughts is, unfortunately, she's got a pretty significant equinus deformity in that residual TMA. I don't know, maybe that's not true, but it looks like that's true, meaning the toes are down because you've taken away those, the dorsiflexors. And if you have an equinus deformity, the problem is it's often not a very functional amputation, even if you can get the wound to heal. It is true, though, that, and I don't know why it's true, but the same thing is true that justifies distal bypass with a synthetic graft. They don't last very long, but they often last long enough to get a wound to heal, and then when the graft fails, you've got at least a healed wound. So I think you don't need to have long-term patency to get a benefit from, below-knee intervention.
Yeah, you have to have a target. You have to have a target. So I think that's one of the challenges we see in some of these cases is that there is no target. And I think that Dr. Eidt is definitely correct. And the other issue I think that most of us have accepted is that it's reasonable to go back in. These are outpatient, minimally invasive procedures. And our goal is try to improve the perfusion to try to heal these wounds. They are long lesions. Sometimes you have to do it multiple times. So, June, what was the thought process here? We were going to do something different here and maybe do some imaging.
Yeah, just one quick comment regarding Dr. Carmen's question. This patient actually was on silastazol. Again, slightly off-label in regards to using it in CLTI patients, particularly those with residual small arterial disease. If patients cannot tolerate hyperbaric oxygen or they're not qualified for HBO for whatever reason, sometimes I do use cilostazol off-label for this specifically. So we wanted to understand exactly why the first procedure reoccluded. For many reasons. Timing, obviously, it was a span of about 6 months between the first intervention to current day. And perhaps it's just purely because of that and the size of the tibial artery. Is it because we did inadequate rotational atherectomy? So all of those things come to mind. So we decided to perform intravascular optical coherence tomography. If you can resume the video. This is a OCT run. OCT is utilized primarily as a imaging modality in the coronaries at this point, but we have used it actually in the below the knee segment as well, and we've done a very nice 40-patient study in our institution evaluating the use of OCT below the knee. Because the tibials are actually very similar in size compared to coronary, it's actually very beneficial. It's hard to perform OCT above the knee, harder, because of the size of the vessel. So I would say that OCT in this current technology, in this stage, it can visualize vessels about 5 millimeters or so. Once you reach 6 millimeters, it's really hard to see the edges of the vessel. So I think it really excels in below-the-knee imaging. As opposed to intravascular ultrasound, OCT uses a very small light camera, much higher resolution, and you can see with better clarity the definitions of the vessel wall. In addition, it also differentiates calcium a lot better than intravascular ultrasound would. Ultrasound, as everyone knows, cannot penetrate through calcium or bone, so there's a lot of shadowing when we do IVUS. In contrast, when we do OCT, we can actually see the nice outline of the calcium. So here we had crossed, and we actually had pre-dilated a little bit because it was initially occlusive. I believe, if I remember correctly, we pre-dilated it with a 2 millimeter compliant balloon. And here you can see that yellow image is the OCT pullback. As it kind of goes through, I'm going to talk through these images a little bit, but there's some dissections that you see, some rips in the artery from our balloon angioplasty. But more astoundingly is actually circumferentially, there's a ring of calcium throughout the vessel. The very bright areas, the very bright yellow areas are essentially fibrotic intimal hyperplasia. And then you can see actually right along the outline, there's about a 1 millimeter thick circumferential calcium, essentially throughout the entirety of the tibial artery. Comments from the panel or audience?
Very impressive. Never see it with
And I wonder from Dr. Eidt and from Dr. Chung, what are the surgical implications? Because when we see this, we basically see in this rim of thick calcium that is completely encasing the artery from top to bottom. What are the implications from this anastomosis? When you open these, I've seen some patients sometimes even when the surgeon has opened to do the bypass, they have not done it because they couldn't find a healthy area to suture because of the calcium. Any comments, Dr. Eidt, Dr. Chung?
Oh, yeah, I think that's a very good point. Angiographically, sometimes the vessel looks open and the lumen looks like it's going to be a good distal target, and you cut down and it's just a lead pipe. So this is a really good image of what that would be like before we actually make an incision.
I can't remember the doctor's name, but she works with Alan Lumsden in Houston at Methodist, and the project they're doing is they're taking the below-knee amputation specimen and doing OCT and IVUS and MRI on the specimens to try to really start understanding what is going on with these below-knee arteries. Because right now we don't really have a very good understanding of what this disease is below the knee. And I really congratulate you for using OCT down here to really try to get an understanding, because I think we're all kind of working a little bit blind. And it's a little bit why we don't get very good results below the knee, regardless of the technique. So I really appreciate you doing this. They're very interesting images.
Yeah, and you can see here kind of peaking at that 2 o'clock position. I think the study you're speaking of actually showed that cadaver legs or legs that were taken for BKA, usually it's a milieu of atherosclerosis as well as thrombus. And perhaps that's one mechanism of how tibial arteries re-occlude. Secondly, you know, it's just kind of speculation. Perhaps that calcium, that ring of calcium, does prevent a lot of our drug-coated technology to uptake. And perhaps that's why, thus far, our DCB trials below the knee have not been very impressive. But ways to modify that, perhaps.
Hey, Peter, there are a lot of these specialty balloons now, like the serrator balloon and other balloons I've seen in the market that are coming out that they have these special, you know, spurs or poking mechanisms that are supposedly to modify these, you know, these arteries and maybe the calcium. Some of these, when you look at these images with the OCT that June was showing, you know, even the calcium is a little bit, you know, the distance from the lumen is way outside in the adventitia. Do you use these balloons, and do you think we should image first to even see if they can reach these calciums and be able to modify them? Peter, I was asking you. Yeah.
Sorry. Yeah. Yeah, so, you know, there are a number of new technologies. You know, we've really found the Serenator to be quite helpful. And then, of course, the other new technology, and shameless plug, I'm going to be talking about it at noontime, is the retractable spur scaffold, which, as you know, has these like little nitinol spikes. And it's been shown in a sub-study that was previously presented and published that they were able to reduce the amount of recoil by over 50%. So recoil is very important, but you know, to your earlier point, June, having a mechanism by which to deliver drug to the target endothelium, I think, is critically important. And so whether it's making cuts with a scoring type balloon, a scaffold, like a Serenator, or using IVL to crack the plaque and allow a mechanism for drug to penetrate into the wall of the vessel, or with the spur device. I mean, I think these are all really going to be critical in terms of being able to actually get the drug to the target tissue and to get enough uptake and hopefully exert a biologic effect.
How far do you think, June, was that rim of calcium from the lumen? You know, if you look at the marker, it's like one marker. So what's the distance?
Yeah, so one marker is about a centimeter. No, it's about half a centimeter.
Half a centimeter. Yeah, my concern is that a lot of these specialty balloons don't even reach the calcium, to be honest with you. You know, they don't reach that calcium. That's why I think that technologies that can potentially go deeper into the vessel wall.
Here it is, 1 millimeter.
Right. You know, 1 millimeter, that's right, yeah. 1 millimeter. So, so it's about 1 to 1.5 millimeters. So it's interesting. I wonder how much they protrude outside of the balloon, and do they really reach the calcium to cause some kind of a poke or a crack in the calcium for us to then get the benefit. But it'd be interesting to see. None of those studies were done with you know, OCT, so it's hard to know. Like you look at here, the calcium is way out. Almost 1.5 millimeters. Yes, Tarek. What are your thoughts?
Yeah, great point, Dr. Shishehbor. I think this is, you know, probably would be, you know, shockwave because it treats the superficial and the deep calcium. So I think, and the other technologies that you mentioned was the retractable spurs. It makes sense. I mean, I saw it last week with the rep, but we don't have it UH yet. I think this technology makes sense for the deep calcium. You know, other modification technology we have now work more on the superficial calcium. And I think one advantage of shockwave compared to atherectomy is that you don't worry about the, you know, the downstream trash of small materials that can, you know, trash the outflow. That's one advantage.
It's entirely true that just scoring the plaque and delivering drug in a calcified lesion will be magical, because there is also longitudinal, you know, transmission. Tony, I don't want to put you on the spot and ask what would you do. That's not the easy question. Do you think that if these calcium in below the knee versus, this is like an ossified vessel, is that right? It's an ossified vessel. So I personally, I don't think there is any ideal endovascular solution to this. The question would be that if we get very good luminal gain even without completely disrupting the calcium, because we won't be able to do that. Is that good enough?
Well, I think we're talking about two different things, right? We're talking about the angiographic result.
Correct.
What we haven't talked about at all is what's the physiologic advantage and what is the endpoint on the tissue perfusion. We've gone through several iterations of devices, and we have more and more being developed, Pedra and others, that just haven't told us when you're done. So I think that disrupting the calcium we learned in the above-the-knee territory was not about luminal gain, it was about compliance change. I think we're going to learn that same lesson in the tibial vessels, that if you improve the compliance, then anything you deliver to the vessel should be delivered better. So lithotripsy, other things that just deal with the superficial calcium, like doing rotational atherectomy, probably is not going to get to this. So you need something that's going to change the compliance, and that compliance will be advantageous for any other device, whether it's bioresorbable stent or whether it's drug-eluting balloon. And then ultimately, we should have tools that tell us, okay, we're done or we're not done, but that's at the tissue level. So I don't think that we've added really the last piece of this puzzle, which is when do we know that we're complete, and it's not just from what the angiography looks like.
And that's the point I was trying to make, and honestly, I think we are learning this a little bit from the coronary folks, as much as I hate to admit it, because they are now doing this image-guided kind of approach, because they do have the tools now. They have the IVL like we do, they have laser like we do, they have other forms of, they have cutting balloons, they have high-pressure balloons, and they are using the imaging to guide them as to whether I should use IVL here, should I use orbital atherectomy here, should I do, high-pressure balloon here? And for us, we haven't really done that. Right. So we, like you said, we go with orbital. Well, it's not going to even reach this calcium.
Yeah, so
and we make ourselves feel good that, oh, you know what, I did atherectomy. Maybe it's going to be better.
At some point, validating fractional flow and reserve of fractional flow in the tibial vessels is going to be something we use. We're doing it non-invasively with CathWorks. We're doing it non-invasively with HeartFlow, Elucid, Clearly. But we're not really using the FFR, IFR technology to determine when we're done. And that could be done at the time of the procedure, but it hasn't been validated properly yet.
So we've actually moved forward in our video now. This is actually, we decided to place BRS because there were significant dissections that we noted on OCT. And even checking in two different angiographic views, you don't really truly appreciate that angiographically. So we did elect to place two essentially kissing bioresorbable scaffolds to tack up the proximal segment of the anterior tibial artery.
Was this one of the commercially available ones, or is this in a clinical trial?
This was commercial. This was done.
Abbott.
Yeah, that was done just a month ago. I think before the era of BRS, the only thing we could do was drug eluting.
In this case, what did you do before? You just did balloon angioplasty?
Yeah, we didn't feel, that's the whole point. That's why the whole point of this is that, Subhash, like without the imaging, maybe we would have done orbital atherectomy, maybe we would have done shockwave, maybe we would have done something, but honestly, we didn't feel that we needed it. We felt like, with some of the tools, we would not even reach the calcium. There were some dissections there that I don't know if you saw in the images on the OCT. So there was some dissection, the calcium was way on the outside, so the issue was that, okay, let's use the balloon, see if we can dilate it. If we can dilate it, then we can just put a scaffold, because we have tried these other things before without imaging, and it recoiled. So this time we decided to take a different approach, but do it with the image guiding, which I do think it takes longer, obviously. It's, you need to learn. I'm lucky I have June, who, and Tarek and Yulanka and these guys, they know OCT well, but, understanding and being to be able to interpret the data is also important.
There is possibility, to use off-label, of course, the new high-definition SpectraWave OCT, which we use in the coronary right now, but we do it exclusively with saline. So you do not need to inject any contrast with it. So hopefully, maybe that technology might be useful here. So that's what I was getting. So your physiologic response was that because there is recoil, if I have a very good acute gain and it is sustainable, that would provide the more durable outcome for the patient. Is that right?
Or at least durable enough to heal the TMA. Right? I think we have to be cognizant of the fact that the end goal here is really to heal the TMA.
So how did you size it? Tell us a little bit about it.
So the sizing, if you can pause the video here, the sizing of BRS, you need to size 1-to-1. One can oversize maybe 1.1 to 1, but definitely not undersized. So it's so important to use intravascular imaging here. If you don't have OCT available in your institution, then ultrasound for sure to help you size appropriately for the BRS. I think we ended up using a 3.5 by 38 and 2 of them kind of overlapping.
June, I hate to interrupt, but because there are a lot of people at different levels in this audience, so I'll ask you again this important question, that sizing based on imaging is slightly more harder than actually it is. Because when you don't have calcium or you have circumferential calcium, you can either go with what is called the medial border, intimal border, or you can go with the luminal border. So in this case of extreme calcification, did you choose the medial EEM border, or where that dark spot is, the ring around that yellow is, that is the media, or you did it based on the luminal diameter, because those two are different?
Thanks for the clarification. So I usually prefer to size using the lumen of the OCT. If you do use IVUS, typically the teaching is to use the EEL, which is essentially the outer border, if you will. There is actually a difference because in our study, we compared patients using IVUS and OCT, and very similar to coronary, if you use IVUS, you actually over-exaggerate the size of the vessel. So measuring by EEL, you actually have to downsize on your scaffold or stent, whichever one you choose to use, by about half a millimeter.
And what is going to happen realistically for most of us who do not have OCT is that we are not going to be able to see the media in this vessel with intravascular ultrasound, so we invariably are going to size it based on the lumen. So I think that's a great point. I think I'm learning a lot from this, but I just want to articulate it because it is going to be crucial for BRS patency.
Yeah. In this particular patient, there was one segment where we pointed out the vessel was very essentially elliptical. So I generally like to size to kind of the larger portion because it really shouldn't be elliptical, or at least when we deploy the BRS, it's not going to be elliptical. So I generally do size according to the longer diameter. And I think you just have to be cognizant of how you size it, regardless of which imaging modality you use.
I'm going to ask you one other hard question. So let's ask in the panel, starting with Yulanka, you have this calcified lesion and Mehdi is not in the room with you and you have the freedom to do what you want to do. Will you put a BRS here or a metallic stent in the presence of dissection? I mean, I would contest, just for spicing it up, Tarek, Mehdi is not in the room.
Yulanka, she has
Soro. No, go ahead, Yulanka. Go ahead and answer. Yeah, I know she's sitting right next to you, so.
Yeah, BRS. No, ideally, I mean, knowing the fact that definitely that vessel closed before, and this is a reintervention, we want to place a scaffold to have that luminal gate for a longer period of time. Ideally, if we have availability for BRS, we would do BRS. So, I mean, the issue with it is economically, the cost of it doesn't make it as attractive overall. So, and this is what we used to do before BRS, is coronary drug-eluting stent with really good result.
Tarek, you have to pick you have dissection in a heavily concentric calcified lesion. You want to put a scaffold. You want to pick a bioresorbable scaffold or a metal scaffold?
I think, like John mentioned, I think the point here is to get the wound to heal. So I think if you put bioabsorbable, and even if this goes down, if you have concern about that, hopefully not. But I think it'll be okay. I think honestly, I probably would have gone either way. Either coronary drug-eluting or bioabsorbable. But I think it's a great point that did not do any plaque modification because the 360 calcium was actually non-stenotic area. And the stenotic area did not have much calcium, it was spotty. So I agree with the approach here, not plaque modification.
See, I think that this case actually, honestly, when we taped it, I didn't even think about some of these things. So it's nice that we are talking about it, But this case really highlights that we did not identify the problem why this vessel failed originally. And this vessel is not failing because of calcium. This vessel is failing because of hyperplasia, of atherosclerosis, aggressive atherosclerosis. And we didn't deliver drug or a scaffold to it the first time. I should have probably, if we had probably done it the first time, you could argue that because we didn't have a problem with expanding the vessel. Now, if we had a problem with expanding, then yes, maybe the calcium would have been an issue. But when we ballooned it and we were able to nicely expand it, we had no issues. So even though the calcium is there, I don't think it was the etiology of the failures the last 2 to 3 times. I think the etiology of the failure was a combination of dissection and aggressive hyperplasia in this patient who has extensive vascular disease. And we never treated it the first 3 times because the first 3 times, first time I did angioplasty, second time we did angioplasty and atherectomy, the third time, this was the third time. So the third time we finally, because of imaging, we said, okay, well, there is a problem. You don't need atherectomy, you need drug, and you need some form of a scaffold. You had a question?
Yeah, I was wondering if anyone has a laser pointer. Laser pointer.
Laser. I think, June, you have a laser on that because you can point to some of there. There you go. Can you show the calcium on that image? Because some people, right. So that's the calcium we're talking about. And when we said, you know, these balloons, specialty balloons that have these, you know, kind of spurs or these pointy metals that are supposedly get to the calcium, the question is that would they make it from the lumen all the way out there to try to disturb those calciums? So that's the calcium that we are talking about.
Yeah, I agree with you. The calcium itself did not lead to this patient restenosing. I mean, it's the disease phenomenon. And the discussion on calcium is really an academic one in terms of how can you make these lesions, essentially your angioplasty, et cetera, last longer? And is it in the calcium modification so that we can deliver the drug?
Well, Mehdi, you're assuming that you haven't achieved failure yet. So I'm really curious as to why you think that when this is the acute result and the other 2 acute results also look good.
So I think that the follow-up will tell the story. You're right. We did this. When did we do this? Because I just saw her last week, actually. You know.
Yeah, we did this before the fellows graduated, so it was beginning of June.
June. So she's doing very well so far. This is still open. It's only been a couple months, so we'll see. But you're right. I mean, I think that, I guess my counter argument to you is that we have a lot of good data with the drug-eluting stents, not bioresorbable, drug-eluting stents compared to angioplasty and to bare metal stents showing much better patency, even better amputation-free survival and limb salvage. So there is something about the scaffold. Now, there is still some failure among those. Maybe those, the calcium is the issue. And you didn't, you know what I mean? Like, because we don't do image-guided therapy for these.
I wonder, you know, it used to be that the cost of coronary drug-eluting stents, first it was the length, it wasn't long enough. 2, then it became the cost, and now both of those things have improved. We have longer coronary drug-eluting stents, and they're way cheaper. So will there be an argument at some point to compare coronary drug-eluting stents to bioresorbable stents in long segments to see, hey, which one of these really, because the only thing that seemed to improve patency, not just you know, target vessel revascularization or wound healing, was the coronary drug-eluting stents in all the early trials. So I'd be really curious to see what that looks like.
Let me just ask one other sort of practical question about the bioresorbable versus a regular commercial available coronary DES. I mean, like right now in our lab where we use a lot of Medtronic, I think we can get a 38 millimeter Resolute for $400, and I'm not sure what the cost of the Abbott Esprit is, but it's probably about 8 to 10 times more. But my other question is more practical, which is we know with coronary drug-eluting stents, you know, if we're a little bit undersized, we can post-dilate them with the bigger balloon, and we won't lose the integrity. So my question is, with the bioresorbable stents, how much more can you post-dilate them if you find that maybe you were undersized when you chose your original BRS?
I believe it's about half a millimeter. You can post that.
But I mean, you know, a coronary stent, you can go a full millimeter, millimeter and a half. So, you know, that's another consideration. I mean, again, for a proximal third to 1/2, from an economic standpoint, there's no question that a coronary DES is going to be a lot less likely to break the bank.
That's right. I think if there are longer BRSs, certainly that's a discussion that can be readdressed. Right now, the tibials are still limited to a maximum length of 38 millimeters.
Yeah, I mean, I think this is also, I mean, Peter, you're hitting the nail on the head, to be honest with you. I mean, the reality is that, we want technology, we want data, we want randomized clinical trials, but then, our reimbursement agencies don't want to reimburse for them. So the science doesn't want to move forward because companies know that this is exactly what we're going to say on the podium. So they spend millions of dollars, they do the trial, and then we sit here, we're like, well, why should we use this device if we can get the other one for 8 times cheaper? And what do you think, Tony? You've been doing this for a long time.
Yeah, they'll come down, though, too. And I think that, science has to keep moving forward. We have 2 bioresorbable stent trials going on right now. One was just completed with Riva Medical, and then there'll be the R3, which, as June mentioned, is a longer stent. So I think we're going to have a chance to sort of look at what is the advantage of having a scaffold that is there for, as Subhash said, just to heal the wound and then be out of the way, because there's some detrimental effects to having tibial stents that are stainless steel that last for a long time too.
I agree. I just want to reiterate one point. Maybe we quoted coronary studies, even in heavily calcified, smaller or medium-sized vessel, the acute lumen gain is a very good predictor. So here you tried to achieve that, and of course we are debating which platform to use. So I think this is a fabulous case because at least when I initially saw the angiogram, I wouldn't have picked this as a reason for failure. I think what you have so elegantly demonstrated that this imaging study actually pinpoints to what was the mechanism of failure of the previous multiple interventions. So it's a simple but a very profound message.
I also want to say from an economic standpoint, an operating room time, anesthesia, clinic visits, and a prosthetic is much more expensive than either one of those modalities.
And the complications, honestly, of bringing in repeated procedures. So I think that's something else to take into consideration. But I also don't want to, I want to reemphasize the point that Dr. Carmen was making about anticoagulation and therapy for these patients, because a lot of these patients that have recurrent occlusion, there is something going on, right? There is maybe some inflammatory process, there may be some prothrombotic process, or it may be an anatomical issue. So I think paying attention to the medical aspect of this is also an important aspect of the care of these patients to keep their arteries patent. Subhash, anything else on your side?
No, I think this is great. June, you want to wrap up and tell us what the follow-up is or not yet?
So this patient is Dr. Shishehbor's patient, but I think you recently saw her in clinic earlier this month, and she seems to be healing well. She is from out of town, so it's hard for her to come see us, but she does visit with us per our regimen, which is kind of every month until things start healing up.
And in terms of antithrombotic therapy, what is her current regimen, if you recall?
So we actually did not change her regimen from before because we didn't think it was a new thrombotic milieu. So she is still on the clopidogrel, Plavix, rivaroxaban 2.5 BID, along with cilostazol.
Along with cilostazol.
That's correct.
I have a question. Was there any concern about the outflow overall, as a potential also etiology? The initial picture of the DP was kind of small as well. Did that get better? Did we use any vasodilators, anything to help?
Yeah, it's interesting. We sometimes see this in some patients is that you get profound spasm in the distal bed. And that's indeed what we saw as well. But typically in her, if you give her about 12 hours overnight, she actually opens up. So the outflow, we agree with you. We actually went in to balloon the pedal arch in an attempt to essentially create more outflow for her. But she, unfortunately, I think with the ballooning, she actually, ironically, spazzed more. So we typically allow a little bit of tincture time to allow the spasm to get better and essentially allow the flow to go forward. But inflow and outflow, very important.
Thank you very much. I think we have a break. Please enjoy thank you, June. That was great. Please enjoy the exhibit hall, and we'll see everybody back here at 10:30 for a number of cutting-edge cases. Thank you so much. Thank you. Thank you to the panel.